Vitamin C gets marketed like a tiny emergency siren for the immune system. But if we strip away the cold season drama, what is the strongest true statement? Is it an immune booster, a collagen nutrient antioxidant support, or mainly deficiency insurance with a better publicist?
The strongest statement is that vitamin C is required infrastructure. It helps enzymes build stable collagen, helps recycle antioxidant systems, supports immune cell function, and improves absorption of non-heme iron from plant foods. Those are not vague wellness vibes. They are normal physiology. The leap happens when people assume that because a nutrient is essential, taking far beyond need must create extra protection. That part is much less reliable, especially for people already eating enough. Collagen is the easiest place to see the difference between essential and extravagant. Vitamin C helps modify proline and lysine residues so collagen strand can hold their shape. When intake is very low, blood vessels, gums, skin, bone, and wound repair can suffer. When intake is already adequate, more vitamin C does not automatically mean thicker skin, faster healing, or stronger tendons. It is a cofactor, not a cosmetic volume knob.
Scurvy sounds like a history lesson, but the packet includes recent cases in high-income countries. Who should take that seriously today? Are we talking about picky eaters, people with food insecurity, smokers, medically complex patients, or anyone who skips fruit for a week?
The people most likely to benefit are those moving from low intake to adequate intake. That includes people with very limited fruit and vegetable variety, restrictive eating patterns, some medically complex patients, burn recovery or surgery recovery contexts, and smokers who have higher oxidative stress and may need more. The scurvy review found modern cases clustered in vulnerable groups, often with multiple body systems involved, which is why clinicians should not dismiss bruising, gum changes, bone pain, or poor wound healing as impossible. Now the dose story. Vitamin C is water-soluble, absorbed in the intestine, circulates in blood, enters tissues by transporters, and excess is excreted in urine. Water-soluble does not mean the body politely uses every gram. Absorption becomes less efficient as doses rise, blood levels plateau, and the gut may protest before the immune system gains anything measurable. That is why dose claims need physiology, not just bigger numbers on a label.
So when someone says, it's water-soluble, just take a huge amount, what is the practical boundary? Is the first problem simply expensive urine, or are there situations where high-dose vitamin C is a bad idea? I'm thinking about diarrhea, stone-prone people, and anyone told they absorb or store too much iron.
For most people, food is the cleanest way to solve the vitamin C problem. Citrus, peppers, tomatoes, broccoli, greens, and fortified foods. Food also packages vitamin C with fiber, potassium, carotenoids, and other compounds, so it improves diet quality rather than just correcting one number. A supplement can be useful when access, appetite, chewing, cooking, or restrictive patterns make food intake unreliable. The win is a dependable pattern, not proving capsules are morally inferior.
I like that because it avoids making oranges the only mascot. The review on Congo Basin leafy vegetables found some species were vitamin C dense on a dry weight basis. Does that change the lesson from buy a pill to look at local plant diversity while still being honest that nutrient composition is not the same as a clinical trial?
Exactly. The useful takeaway is not that one exotic leaf becomes a supplement commercial. It is that vitamin C adequacy can be built from culturally local foods. That Congo Basin review found wide nutrient density, including vitamin C, but also said clinical and intervention studies are still needed. So we can respect food composition evidence while not pretending it proves infection prevention, skin transformation, or chronic disease protection by itself. For colds, the key distinction is regular intake versus starting after symptoms. Evidence has generally pointed to modest, context-dependent shortening of cold duration with regular vitamin C, not a dramatic prevention effect for everyone and not a reliable rescue once you are already sneezing. People under heavy physical stress may be a different context, but the average office cold is not a megadose emergency. The honest promise is small, probabilistic, and timing dependent.
Where do you draw the line between harmless cold season optimism and something risky? If someone uses vitamin C to avoid vaccines, ignore worsening symptoms, or replace sleep and food, that feels like a different category, right? And if fever, breathing trouble, dehydration, chest pain, confusion, or symptoms that keep getting worse show up, a supplement should not be the plan.
Right? The biology is real, but not invincible. Immune cells generate oxidants as part of killing microbes, and vitamin C participates in redox balance and cell function. Adequate vitamin C is like having working wiring in the immune building. But if the building is sleep-deprived, malnourished, unvaccinated, or facing a serious infection, adding more wiring does not replace the rest of the structure. It supports a system, it is not the system. The newer trial literature also teaches humility. In COVID-19 nutrition trials, vitamin C plus standard care showed a decrease in IL-6 in one network meta-analysis, but the certainty was low, and that does not convert into a home treatment promise. In malnourished patients at risk for pressure injuries, formulas containing vitamin C plus protein, zinc, arginine, and other nutrients showed trends, not clean proof that vitamin C alone was the active ingredient. Sick, malnourished, and hospitalized people are not the same evidence category as healthy shoppers.
That makes the cardiac arrest trial stand out. If 10 grams of intravenous vitamin C actually looked worse for organ function outcomes, should viewers treat that as a warning against assuming hospital-strength dosing is automatically better? I also want people to hear that intravenous dosing is a medical intervention, not a pantry upgrade.
Yes, the practical version is simple. First, ask whether your regular diet supplies vitamin C most days. If yes, a big supplement is unlikely to transform immunity. If no, fix the food pattern or use a modest supplement to reach adequacy. Judge success by fewer deficiency signs and better dietary reliability, not by expecting invulnerability to colds. And if you have a history of kidney stones, an iron overload disorder, pregnancy complications, serious illness, unusual symptoms, or planned high dosing, bring a clinician into the decision before experimenting.